Okay, I'm sorry for all the cable trouble and such like. I'm going to try and go over this skull, the internal part of the skull, and apart from the introduction, more or less follow the checklist that you have. And to start with, if you remove the calvarium, primary point to appreciate is that there are three cranial fossae: anterior, a middle, and a posterior. And in this skull, the demarcation between them has been outlined in red. So demarcation between the posterior and middle is the top of the petrous bar of the temporal and the dorsum celli, the part of the bone just behind the sella turcica. And the demarcation between the middle and anterior is the lesser wing of the sphenoid and the part of bone anterior to this sella turcica. Anterior, middle, posterior. This will be more obvious if I show you a skull in which the three fossae are colored. In blue is the posterior, in red is the middle, and in green is the anterior cranial fossa. Now you might appreciate from this skull that the bones, which are of most importance and contain most foramina, are the sphenoid, seen here in red, forming the anterior part of the floor of the middle cranial fossa, and the sella turcica for the pituitary. And the other bone, the temporal. You see here forming the posterior part of the middle cranial fossa, the petrous temporal bars of bone separating from the posterior fossa and some of the posterior fossa. Most of the rest of the posterior fossa here is formed by the occipital bone. Now I'm going to take this particular skull and try and point out the major features of each fossa. And as I do this, could we have the camera close up on this anterior part, this part? That will be all right. Can you sharpen that focus, or is it in focus? Okay, you see here in two green patches, these circles are placed on the orbital plates. Beneath this will be the orbit. On top of it, in life, will be sitting the frontal lobes of the cerebral hemispheres. In the midline, here, there is a ridge, a crest of bone, the crista galli, which means coxcomb. It is part of the attachment of the falx cerebri, a layer of dura, tough connective tissue which separates the right and left cerebral hemispheres. Part of it is attached here, and the rest around the calvarium, which I'll show you later. On each side of this crista galli, there are a series of openings, pores. This is the cribiform plate in the ethmoid bone, and through those several foramina, some 20 odd, the various parts of the olfactory nerve from the olfactory sensory part of the nasal mucosa come back into the olfactory bulbs and thence into the brain. These are the major features of the anterior cranial fossa. Now, if we can have the camera on this central section, that's it. That's it. You'll see again two circles, red circles, simply indicating that these are the temporal fossae of the middle cranial fossa, in which the temporal lobes of the cerebrum lie. If we come to the middle here, there's a red mark I'm touching, which is right in the center of the sella turcica. And in this depression, in the sphenoid, the pituitary gland lies. If you look on your skull just anterior to it, there's a foramen going in here. I'll put a marker in it. In here is this piece of red wire. This is the optic foramen, where the optic nerve returns from the retina of the eye, and this cross mark of red is the optic chiasma, or where it lies, really. It's not here. It's the position of the crossover of the optic fibers. There are two projections here, an anterior clinoid process on each side, and posteriorly a posterior clinoid process on each side. These are the sort of fore and aft parts of this sella turcica or Turkish saddle. Laterally, there's a faint groove on each side of the sella turcica. That is the carotid groove. The internal carotid artery runs in it, entering the cranium here in this rather irregular shaped foramen, the foramen lacerum, and running forward here under the anterior clinoid process and then turning up to contribute to the circle of Willis supplying the brain. Posteriorly, on the anterior surface of the petrous temporal, that is this bar here, there's a faint depression marked in red here. This one. This is the trigeminal fossa, where the trigeminal ganglion sits in life. Trigeminal ganglion of the fifth cranial nerve. And apart from those major features, there are a series of foramina, other than those I've mentioned. One of these on each side is here under this lesser wing of the sphenoid. I'm sticking a pencil in. I'll put a piece of wire into it. If I turn the skull round, you'll see this is coming directly into the orbit. That fissure on each side, here and here, is a superior orbital fissure. And through that, the ophthalmic branch of the fifth nerve, the third nerve, the oculomotor, the trochlear, or fourth, and the abducens, or sixth, all pass into the orbit. Notice there are two entrances to the orbit, this one for those nerves, and this one medial to it for the optic nerve. The optic nerve with the ophthalmic artery enter separately to the rest. Just behind this superior orbital fissure is a small round opening. If I can get a piece of wire in it. Which is the foramen rotundum. Through that, the maxillary division of the fifth nerve passes. Posterior and slightly lateral again to that is an oval opening, the foramen ovale. Through that, the mandibular division of the fifth nerve passes. Posteriorly and laterally again, there's a small opening, a very small foramen, the foramen spinosum. Through that, the middle meningeal artery enters the skull. And on most skulls, you can see fairly distinctly a groove running laterally from it and dividing into a posterior and an anterior branch. These grooves are made by the stem of the middle meningeal and then by its anterior and posterior branch. These arteries and their branches lie right up against the skull, actually in the dura. And they may be fairly easily torn by a fairly heavy blow on the skull, even one which does not cause a fracture. It may cause the dura in that vicinity to rip, and therefore rip the middle meningeal or its branch, in which case you have arterial bleeding into the cranial cavity, which will build up pressure on the brainstem, and if this is not treated, cause death from interference with vital centers. Now, if we go into the posterior cranial fossa, that's right. Now have two large blue circles to indicate the parts of the posterior fossa which are the cerebellar fossae. The hemispheres of the cerebellum lie in this and lie below this blue line. In the midline, there is, from the foramen magnum, there's a crest, the occipital crest, and it terminates here in a projection, an internal projection, which is the internal occipital protuberance, corresponding internally to the external protuberance on the outside. Now you'll see in this skull, in this posterior fossa, grooves on the bone. In this particular case, there's a groove starting here and running round laterally and then turning in an S-shaped curve and running down to the jugular foramen. I'll put a marker in the jugular foramen. This groove will terminate where this red piece of wire is sticking, at the jugular foramen. Now, in various skulls, these grooves will vary considerably. In this particular skull, they are quite symmetrical. There's a well-defined one here and a well-defined one here. But very frequently, you'll find the one on the right is large and the one on the left is very small. Uncommonly, the reverse may be true. The one on the left may be large and the one on the right be small. These grooves are made by the transverse venous sinus, pathway of major venous drainage from the brain. This transverse sinus runs transversely or laterally, and when it reaches this point where it turns down in an S-shaped curve is then called the sigmoid sinus. That exits through the jugular foramen and then becomes the internal jugular vein. The fact that the grooves are often asymmetrical simply indicates that these large sinuses are often asymmetrical, so that one may have dominant brain venous drainage on the right, most commonly, equal on both sides in about 1/4 of people, and left dominant in about 1/4. In other words, about half of individuals show a right-sided dominance. Now, if you come back to this internal occipital protuberance, this is the point where these sinuses are formed. They're formed by the superior sagittal sinus, which, if you look on the inside of the calvarium, this is the skull cap. You look on the inside, you'll see a groove running from anteriorly, actually starting by the crista galli and running back in the midline, and in position it would end up here. That's the superior sagittal sinus. Now, while we're looking at that, notice that on each side of this there are little pits in the bone. They will vary in their depth and extent. These are made by the arachnoid granulations, devices for return of cerebrospinal fluid into the venous system. I'm going to substitute this skull with one where these venous sinuses are more heavily marked, make them more obvious. That's right. Here again is where the superior sagittal sinus is coming in. It then in effect branches into a right and left transverse sinus, running around the skull, becoming a sigmoid, going through the jugular foramen, then becoming the internal jugular. You cannot show another sinus because it lies in dura across here. It's not against the bone and doesn't make a mark. This is a straight sinus. To reiterate that, the superior sagittal sinus and straight sinus join at the internal occipital protuberance and then branch to give a right and left transverse, which becomes sigmoid, which becomes internal jugular. Now, in going through this skull so far, we have dealt with the foramina for the first nerve, the olfactory, going out through the cribriform plate or coming back in through it. The optic foramina, going into the orbit for the second nerve. The superior orbital fissure for the third, fourth, and sixth, and the ophthalmic division of the fifth. The foramen rotundum for the maxillary division of the fifth. The foramen ovale for the mandibular division of the fifth. So we've dealt with 6 of the cranial nerves to this point. If you go into the posterior cranial fossa, on the posterior aspect of the petrous temporal, there's a foramen, which I'm sticking a wire. This is the internal auditory meatus. The 7th and 8th nerves leave the brain and enter this foramen. The 8th will not go out. It will stay in the petrous temporal bar as it's going to the internal ear, which is located in this bar of bone. The 7th will have a rather involved course, running first laterally, then posteriorly, then downwards, to emerge at the stylomastoid foramen. This foramen here on the base of the skull, between the mastoid process and the styloid process. The 9th, 10th, and 11th all leave by the jugular foramen with the sigmoid sinus. The 12th leaves by the hypoglossal canal just at the margins of the foramen magnum. Now those cover most of the features, but you have a checklist with all the features you should know. Notice that most foramina run straight through. That is, where you see them on the inside, if you push a probe or something through, you'll find they're emerging in the same place. But a notable exception to this is the foramen for the 7th nerve, which I've just described. It leaves via the internal auditory meatus and has a complex course in the petrous temporal bone and finally emerges relatively distantly at the stylomastoid foramen. The 5th maxillary division, going through the foramen rotundum here, is going to go into the orbit and run across the floor of the orbit in the inferior orbital canal, and its termination emerge at the inferior orbital canal on the face. Those are nerves. Now, one of the more puzzling features, if you don't get this straight, is the course of the internal carotid artery. The internal carotid is going to enter the skull right here. This foramen is the carotid foramen, and it's immediately in front of the jugular foramen. But it does not go straight through. It runs a medial and anterior course and emerges inside at this foramen, which has a variable shape, the foramen lacerum. So it has a course from outside about here to inside about here, something like an inch long, running in the petrous temporal in the carotid canal. Nothing goes directly through, no major structure goes directly through the foramen lacerum. You may have a hole going through there, but the floor in life is filled in by cartilage. It is not a true through-and-through foramen. The carotid then runs up on each side of the sella turcica. Now, as we've had a lot of difficulty with television, I think I'll leave it at that point, and you should look at your skulls and consult with your instructors for the various points on the checklist. And don't forget, there are also some points which may be duplicated, may not, which are in the dissection manual at the beginning of the head and neck. Finally, one other announcement. Commencing on Monday, there will be someone on duty in the television studio up till 6:30. So after the formal end of class, if you wish to, you can request any of the movies and have them shown up till 6:30. Okay.